Hi, everyone. Thanks for this interview. This very nice, important question. Just we know that carbapenem resistance is a huge problem. We know also that to treat infection due to carbapenem resistance, we have a lot of different drugs like BLI. We're just thinking about ceftazine avibactam and all new drugs that are coming. So each drugs has to place in therapy. That's when you think about why we have all these carbapenem resistance, and we need to go like in the last 20 years and think about how much carbapenems, how much meropenem we use worldwide. So here we need to focus on the gram-negative and on ESBL, more OMC, gram-negative bacteria. So bacteria that have some resistance, so we need meropenem. If Temocillin, in this case, is coming from the past because it was marked the first time in the 80s, and now is coming back. Now we can see because Temocillin is present a narrow spectrum, so it's active only against Enterobacterales, so only in a type of gram-negative, and also is resist against the hydrolysis of ESBL OMC enzyme. So seems to be very advantageous drugs against this kind of resistance. So which kind of antibiotics sounds like Temocillin nowadays? Maybe we are using, instead of carbapenem in this kind of infection, multi-drug resistant infection, but not carbapenem resistance, we can use piptazo, but we know that the data from the literature are controversial, no? How piptazo is inferior, maybe against carbapenem, or superior, no? We know the Merino trial, all this controversial about this. We also know that there is some other antibiotics. We think about amoxiclav, no? If the ESBL could be susceptible to amoxiclav, but also amoxiclav, piptazo, we used to use against other infections, against other type of bacteria. So thinking about which kind of drugs we could have in this moment, that's answer like Temocillin. I think that we don't have anything like Temocillin. Focus on infection due to Enterobacterales that present ESBL or MSI enzyme. So I think that in this very narrow spectrum, Temocillin is very good. Of course, my consideration of the first question came with the preliminary result on Astarte. This is what I would say. I know inferiority trial, so we put like Temocillin versus meropenem. So the main result, we use a composed variable that was formed by clinical cure, the test of cure, the no change of drug or study drug therapy for adverse event or failure, the recurrence until day 28 and death at day 28. So these four variables we join in one clinical success that we use to measure the impact of Temocillin versus meropenem. And the result was that there is no difference between the two arms. We achieved the clinical success, the 71.5 patient in both arms, there is no absolute difference. And the inferior margin that is important in this trial, it didn't go down within the 10, that we use like 10% as our threshold to confirm the non-inferiority. So I think this the main result, and also very interesting that this result, so a very low difference between Temocillin and meropenem, we also reported in subgroup of patients. we know that with the non-inferiority threshold doesn't apply in this subgroup of patients, of course, but if you look at the data, there is a low difference in different subgroups. So we think that we can find regarding considering these preliminary data, we can find a place of therapy. So we would use comfortable use to use Temocillin in E. coli bacteremia, in urine tract sores, and in regardless of severity, with sepsis, not sepsis, sepsis shock or not. Maybe looking at the data that we presented yesterday, we will be more careful using Temocillin in such subgroup as immunosuppressive patient, other enterobacteriales, other source of control, due to the low number of patients in this population. And finally, we think that the preliminary data are very interesting. We are looking for the final data, and we hope to publish as soon as possible to share with all clinicians our experience. Yes, I think that a little bit answer in the before that in our trial, considering our data, well, due to the low number of biliary tract, intra-abdominal, no biliary tract, and other source of bacteremia, we couldn't draw conclusion or suggestion about the use of Temocillin. And also due to the low number of other enterobacteriales, we had like a 20% of Klebsiella pneumonia, and the remaining 8% composed by different kind of bacteria. Well, actually, we don't have also the capacity to draw a strong conclusion in others. So maybe in this setting we need more data to answer. But we know that Temocillin can achieve all the infection, can achieve the central nervous system, the intra-abdominal part, the lungs. So Temocillin have the capacity, like PKPD characteristic, to achieve all different part of our body. So to fight against infection in different kind of, not only urinary tract. Also, we know that in urinary tract, Temocillin is very well concentrated. So for this reason, maybe we will prefer to use in the future in this kind of infection. But on the other side, also we know that in the enterobacteriales, the urinary tract infection, the urinary tract source is the most common. So in this view, we can, maybe in the future, we could change our practice, and also in this kind of patient use Temocillin instead of carbapenem. So we hope to give some important data to start and to help the carbapenem sparing strategy in this infection.